And the next speaker is Khazhylenko, who is from Isida Clinics that you saw the video. And she will introduce you to endometrial issues and from the clinical perspectives. So please welcome Kseniia.
Good evening, Khazhylenko, and firstly, I would like to thank organizers for inviting me for this nice meeting, and I would to present you endometrial receptivity, and starting to preparing of this presentation was a challenge for me because to explain something for scientists is quite difficult. It's uncommon for me, and I was a bit worried about how it will be, and then I calmed down after I saw some post in Facebook, in page of event organizer on Facebook, where it was this information about speakers and about me with these words: please, for scientists, please don't panic if you are not in field. And it was a bit funny for me because in the same time I addressed to my colleagues with approximately the same words: please don't worry. So scientist, it's not so afraid, so calm down. So I'll try to explain you something about endometrial receptivity. And first is very, very easy. All you know that for implantation, for pregnancy, we need just embryo, just endometrium, and dialogue. But as well known, for normal implantation and for normal pregnancy, we need that embryo will be euploid, endometrium have to be receptive, and dialogue have to be effective. Yeah, thank you. What does it mean effective? Effective means that normal healthy endometrium react on euploid embryo in some known way, and it means that in euploid embryo, endometrium start to prepare by migration of stem cells to place of possible implantation. And if embryo is euploid, reactions start in production of new vessels and invasion process. And in case if embryo is aneuploid, so reaction, this friendly environment could change on the field of the war, and reaction can be absolutely different with dramatically increased number of immune cells, and next pro-inflammation reaction could block implantation, and it stopped. Then what does it mean? How can embryo and endometrium talk each to other? And some years ago, Nick McClone with his team proposed very impressive theory, which I like so much, and I would to present it to you. And according to this theory, euploid endometrium is metabolically quiet. It means that it no need to spend energy on some other things apart from development and growth. At the same time, aneuploid embryo can be metabolically noisy because it needs to investigate his energy on additionally on apoptosis and repairing. And endometrium can listen this noisy and react by blocking or permission of implantation. So it's, for my opinion, it's answer on the question who is the main in the process of implantation. And of course, this question is very important for all reproductologists. And of course, I'm sorry, of course, for finalist scenario, embryo is the main because from euploidy or aneuploidy depends will be this pregnancy result in delivery and newborn or no. But process of permission, process of implantation depends only on endometrium as a sensor or biosensor of normal euploid embryo. So what does it mean endometrial receptivity? It means that there are some parts of this process. First is preparing of endometrium, despite on euploid, on aneuploid embryo will be the next. First step is embryo identification, and then, endometrium makes a decision to be or not to be of implantation. So endometrial receptivity means short period of time when luminal epithelium of endometrium is favorable for embryo adhesions. What does it mean short? Short means that previously it was concerned that this period of time is approximately 4 or 5 days. But now in era genetic testing of implantation window, it's known that this period is much shorter, and it starts 6-8 days after LH surge and continue not more than 1-2 days. For normal endometrial receptivity, we need maternal control. Unique feature of human endometrium that process preparing for future implantation is independent on conception or not. This process depended just on follicular genesis, so just ovulation or anovulation is the main in preparing of endometrium to implantation. And during this period, on influence of estrogen priming till LH surge, endometrium prepared by growing, and then after an LH surge, it change on progesterone influence. So how does endometrial receptivity work? During proliferative first phase of menstrual cycle, after estrogen influence, DNA synthesis start and with cell proliferation. Then this process is growth factor dependent, and during this period apoptosis is suppressed by anti-apoptotic factors. It's very important because we no need any apoptosis during first period of menstrual cycle. Then after ovulation, after LH surge, some apoptotic process started because they need for blastocyst invasion. But also balance between apoptotic and anti-apoptotic factors is very important. In the same time, decidual proteins and immune cells start to product. And it's very interesting, and it's also interesting as different group of regulators of implantation process as growth factors, cytokines, and different molecule of adhesions and downstream transcription factors. But all the time I need to remember that I'm clinician and I need to give you just clinical information. So I'll continue as a clinician, and I want to show you that embryo could implant anywhere except of non-receptive endometrium. What does it mean? It means that if embryo get to some other place, in case of out of time implantation window. It could implant in uterine tube, in ovarian, anywhere. And it means that if embryo get to the uterus out of implantation window, and if in the same time in the uterus will be some part of epithelium injured previously, for example, it can be scar after cesarean section or after myomectomy. Embryo rather implant in this place than in normal endometrium, because nothing forbidden implantation in this injured luminal epithelium. So endometrial receptivity can be impaired in different ways. First, it's impaired in time. It can be early or later than normal period. It can be impaired in place. I have already mentioned this. It can change in selectivity, with resulting in superfertility or infertility. It can be impaired in effectiveness, decreased because of different reasons, some uterine endometrium diseases and so on. And it can be, could it be non-receptive? Principle, even healthy women can, in anovulatory cycle, as I have already mentioned, can have non-receptive endometrium. But in severe cases, the reason of non-receptive endometrium can be in severe injury of endometrium after, for example, curettage or some severe inflammation of endometrium and utero. So about endometrial selectivity and their changes. So as in usual life, selectivity should to be normal, because just normal selectivity resulting in a normal delivery and healthy newborn. In case of increased selectivity, it means that any embryo, euploid or aneuploid, getting in the uterus don't have a chance to be planted. From the other side, decreased selectivity can be absolutely different, but the same problem with cases when any embryo, euploid or aneuploid, getting to the uterus have a chance, all the time have a chance to be planted. But result of this problem will be in miscarriage. The reason of superfertility, so-called superfertility, can be prolonged time of implantation window, often because of gene expression changes and next changes on producing decedulization proteins. And as because of this prolongation, period of implantation window becomes longer, and compromised embryo could be implanted during this longer period. Clinically, it manifested by shortening time to pregnancy. Couples with superfertility became pregnant much faster in comparison with normal fertile couples. So, for example, if normal couples become pregnant during 6 months, couples with superfertility become pregnant almost 100% during not more than 3 months. And even if embryo in condition of superfertility implant, it can be prolonged window of implantation could be a triggering of placenta pathology with late obstetrician complication and so-called fetal origin adult diseases. This is a very interesting group of diseases when in adult life, diseases like osteoporosis, some cardiovascular diseases, and diabetes in origin not from childhood but from early pregnancy, from implantation period. Sorry. Oh. How can we measure or assess endometrial receptivity? Starting from 50s, when used practitioners used just NOI criteria, histological criteria of NOI during many years. A bit later, there were added immunohistochemistry and pinopodia assessment, but all these parameters are just markers, indirect markers of endometrial receptivity. They used still till now, but they are indirect. And now, in era of omics era, when we are talking about endometrial receptivity, often we means that we are talking about endometrial receptivity array, so assessment of gene expression. I think next topic will be about this very interesting assessment. So let's continue. The reasons of compromised endometrial receptivity could be different diseases of endometrium and utero, which could result some different type of pathology, like pro-inflammation reaction and some change in steroid production. Sometimes the reason of compromised endometrial receptivity could be uteropathology, different type of pathology with abnormality of utero and injury of utero after curetages or endometriosis like Asherman syndrome and so on. And one more, very important reason is ovarian stimulation in patients with IVF program, when the reason of changes in receptivity is a process of stimulation, when because of supraphysiological level of estrogens and very early prematurity rise of progesterone, endometrium became absolutely inadequate for embryo implantation during this IVF program. So could we improve something in a patient with impaired endometrial receptivity in IVF program? Why not? If we, we know why and we know what to do. In case of asynchronity, we can use a freeze-all strategy when we freeze all taken embryo and then transfer them in next natural cycle. In case of superfertility, implantation all the time is blind and random event. So in this patient, clinically, they manifested by recurrent pregnancy losses. And in this group of patients, we use pre-implantation genetic screening with choosing normal embryo and transfer them in the utero. In patient with off time implantation window, we need testing of gene expression and targeting and embryo transfer depending on period of time when displayed the implantation window. And in patients with decreased endometrial receptivity, what should we do? We can theoretically use adjuvant therapy, so-called, and it means that different attempt to improve situation with change in endometrial receptivity, but all this medication mentioned here in this slide, like aspirin, low molecular weight heparin, luteal phase support, immunoglobulin therapy, and growth factor using systematically or local insulin synthesizers. All this medication, unfortunately, don't have enough evidence of their effectiveness. And stem cells therapy with patients with decreased endometrial receptivity could be the future of impaired endometrial receptivity treatment. This is our hope. And I thank you for your attention. This is part of our team, and this is part of our team too. This is just part because somebody have to work in the same time. So thank you for your attention. If that's all.